new-onset dilated cardiomyopathy, we're just going to briefly do these definition, diagnosis, treatment, prognosis, with most of this being focused on diagnosis and prognosis. So the definition's changed over the years. It used to be pretty broad, just said the heart muscle's not working, we don't know the cause, and we rule out the more common things. As time went on, it became slightly more specific, and the definition was made to help distinguish between familial genetic and non-familial non-genetic causes. But of course, we're always excluding the stuff that we know is common, more so based on demographics, but things like coronary artery disease, valvular, congenital, and even ion channelopathies. So it can be a confusing term because you hear things like dilated cardiomyopathy, non-ischemic cardiomyopathy, myocarditis. You know, I would say that maybe using dilated cardiomyopathy and non-ischemic cardiomyopathy are almost interchangeable, but that's not actually how the guidelines or how the definition is put out in the literature. Well, we're going to use the term dilated cardiomyopathy. So it's pretty common, actually. It has a prevalence of about 1 in 250, accounts for about 10,000 deaths per year. And something I didn't know prior to this talk was that it's the primary indication for cardiac transplantation. But it really makes sense because a lot of these people tend to be younger. You've ruled out other more serious comorbid conditions, at least in terms of like other cardiovascular comorbid conditions. These patients can have variable presentations sometimes, or I should say most of the time, it's sort of progressive, like this patient, where things started in May and then went on. It can be difficult to predict prognosis because we're still struggling a little bit with giving definitive diagnosis. And I'll show you slides in the next couple slides that 20 to 30% of the patients are idiopathic. I guess it's always a little unsettling when you don't know precisely what the cause is. But that in itself has actually become an etiology. And you want to exclude other conditions because there can be a lot of phenotypic overlap. And I mentioned that earlier. So here's a nice diagram that shows you how you can broadly think about it. So if you take the 20 to 30% and push them off to the side that end up being labeled idiopathic, there is some newer ways of working that up, which I will show you a single slide of that in the future, and that has to do with genetics. But for the most part, you can look at these broad categories. So was there something that caused inflammation in the myocardium? And you can see there's a whole host of things. Was it something in the environment that they were exposed to or had a lack of? And so we think about tachycardia-induced. I don't know why peripartum falls in that, but I assume it has something to do, they're relating that to maybe the hormonal changes or the fetus being in an environmental toxin, for lack of better words. But alcohol, iron overload or siderosis, chemo, we know. And then perhaps more interesting in the next couple of years will be this idea of the familial hypercardiomyopathy. And there's been a lot more work in regards to genetic analysis and coming up with a more precise etiology for those. So there's some things about dealing with dilated cardiomyopathy or non-ischemic cardiomyopathy can be a little unsettling. And taking a thorough history, which includes everything I have listed here, is really key. And that's going to be the primary way that we narrow our differential and feel more comfortable with counseling our patients and telling them what we think it is. Echo, although still our greatest tool when it comes to imaging, really just tells us it's there, but it may not always define an etiology. I'm excluding, things that are obvious, like if someone has non-compaction, where you might be able to see it clearly on an echo. But for the most part, if you're looking at an echo like the one we just saw, the echo wouldn't push you necessarily in one direction versus the other. So we advocate for doing serologies, and you should always consider cardiac MRI on any patient that comes in with a dilated non-ischemic cardiomyopathy for two reasons. It might provide you with an etiology, but there's some literature that's evolving, and there's some ongoing trials that shows it might help us determine risk of ventricular death in the future. And endomyocardial biopsy is not something that's routinely done here or even really nationally anymore, except at some centers. We're not talking about biopsy on transplanted patients and things like that, but for the purposes of diagnosing a cardiomyopathy. And we'll talk about that in a little bit. So the typical workup, again, spend a good 10 minutes at least, at a minimum, 20 minutes maybe, getting a history and maybe being really invasive in your questioning. It's always important to do a physical exam, even more so when you're looking at the possibility of like a more systemic illness, sarcoid, lupus, autoimmune disorders, an allergic reaction with reactive eosinophilia, things like that are all helpful. Doesn't take long to do. ECG and chest x-ray. This doesn't necessarily lead you down towards a diagnosis, but it certainly helps you out. I mean, if someone had a chest x-ray with lymphadenopathy and they fit the profile for possible sarcoid, that might help you. ECGs, again, you're looking for tachycardia, you're looking for conduction delays, which can be supportive of your diagnosis, again, if you think there's an infiltrative pattern. Here's just a sampling of some serology that you might consider getting. And again, none of these in themselves are diagnostic per se, because someone could have Lyme disease, and that doesn't mean that they necessarily have a cardiomyopathy related problem with it. But these are things that you should consider in the context of your questioning, in the context of what you clinically suspect. Cardiac MRI is really the gold standard for looking at heart volumetric calculations, ejection fraction, so on and so forth. Looking at the pattern of late gadolinium enhancement can be helpful in two ways. One, it can help with determining the etiology, but it also, as I mentioned earlier, and we'll expand on that in a little bit, it can help determine prognosis. And what's perhaps more settling is that the tissue characterization techniques that are used on with CMR, like late gadolinium enhancement, T1 mapping, the measurements of the extracellular volume fraction, T2 mapping, all these things, they have been validated against histological findings. So they are fairly accurate, I would say. Here's just a couple pictures. We won't go into great detail. On the upper right hand, you can see it's labeled as sarcoid. And CMR is really the preferred imaging modality now for detecting cardiac sarcoid. And I believe the Heart Rhythm Society put out a statement saying that, if you do an initial screening for sarcoid and you have reasonable suspicion, then cardiac MRI is recommended with a high level of evidence. Assuming you're in a center where it's people are proficient at doing it, but you can see there's a patchy distribution in this particular image in the late mid-wall, and you can also see you can see epicardial late gadolinium enhancement. This is a dilated cardiomyopathy, which is what this talk is about. And one of the characteristic findings, or I should say it's seen in approximately 30% of individuals, is this mid-wall, this mid-wall stripe pattern. And it's thought that this is, just with all processes, the late gadolinium enhancement suggests pathological tissue, right? And so this is suggestive of myocardial fibrosis, and I'll tell you why that may be important in the future. Myocarditis, so we could use an example of viral myocarditis maybe. You might see some patchy epicardial mid-wall, late gadolinium enhancement, and oftentimes you see it along the lateral wall. And we're not going to talk about pulmonary hypertension. So the reason it's becoming an important diagnostic test is because it's been used to potentially predict outcomes, and more specifically mortality, which we care about a lot, and ventricular arrhythmic events. And so it's been studied over the course of many years. There's been a lot of meta-analysis published. And if you're trying to determine management or primary prevention of sudden cardiac death, and you were to use our current criteria, you might miss a certain population of patients. And if you think about the patients that present with new-onset dilated cardiomyopathy, they tend to be younger. And so using that cutoff of an ejection fraction less than 30 or 35% could be misleading, as opposed to looking at things like the amount of fibrosis within the wall. And we use LGE as a surrogate for that. And there's a study going on right now, currently recruiting, and to look precisely at this. We're putting an ICD in patients who have a higher EF than what we're used to. Would that, be beneficial for prevention of sudden cardiac death? So interesting. LV non-compaction is another thing you can pick up, and you can see this on echo, but sometimes it can be real challenging to differentiate between normal LV trabeculation versus something that's pathological. And so this LV non-compaction is characterized by an extensive amount of LV trabeculations. And there's there are different ways of calculating that. The more common one is when you look at the ratio of compacted to non-compacted myocardium greater than 2.3 to 1. So that's a fairly sensitive and specific finding based on some studies done in the past, but it's another way to diagnose disease. Not much to say about the muscular dystrophies, but it would be unusual if this was the first time someone diagnosed. I mean, a person with muscular dystrophy is going to have other signs and symptoms leading up to the cardiomyopathy, but just an example that you can see abnormalities. One other thing that we don't commonly I don't think we always think about this, but any type of myocardial iron overload, so a chronic sickle cell patient, someone who has hemochromatosis, which could be inherited, you can use cardiac MRI to diagnose this. And what they use, and I am not going to be able to, this is a very superficial look at what you could use MRI for, because I'm not an imaging person, but they use a thing called a T2 relaxation time. And they use a cutoff, and this is just an image of how you can see the signal changes over time, or the signal intensity changes over time until you get to the end picture. And this allows you to calculate T2 relaxation time, so anything less than 20 milliseconds is considered abnormal. So again, if you have a history that points to this, cardiac MRI would be a useful test, but you may make that clinical assumption just based on the history if you're thinking about cardiac siderosis. Here's a schematic. It just points out what I already told you, which is that there are various techniques that have been validated that can help us. And now we're starting to think about, how do we counsel regarding devices and medical therapy. Endomyocardial biopsy, not something that we do routinely, and this is just a picture of what it might look like. You're using your device to actually grasp the right ventricular tissue. I mean, you can do an RV and an LV biopsy, but this is not. So one of the things that gets stressed over and over in the guidelines is if you're going to do a myocardial biopsy, you should have operator proficiency, and you should have a pathologist that is skilled in cardiac pathology. In the absence of that, the sensitivity and the specificity goes down significantly. So keep that in mind when you order, if you ever consider ordering such a test. This is a study published in 1994, and it was based on histopathological findings, so cardiac biopsy. And I take this with a grain of salt, but what they determined, and they don't really explain in the study, what criteria they were using. So, for example, they looked at a biopsy on someone who was chronic alcohol abuse. Okay, so was it the absence of certain findings plus the clinical history that suggested it was chronic alcohol abuse? So the point of this slide is just to know that there's a lot of patients that, at least in 1994, at a very experienced center with a high volume, that they still were unable to characterize as any one etiology, but rather called it idiopathic. That's sort of been narrowed down. As I showed you in the beginning, we really consider that to be about 30% of our patients at this point, and that probably has something to do with the fact that we use cardiac MRI and we just know more. So the recommendation, so the ACC, AHA, and the European Society recommend 14 clinical scenarios, which we are not going to go through, but I just want to mention a couple that are based on this is based on expert consensus for the most part, but there are lots of other descriptive studies, retrospective, prospective, some randomized trials. Actually, I didn't see any randomized trials. But the complication rate has to be taken into account, and luckily it's very low. This is based on 7,000 patients, and the most feared complication of perforation or death is excessively low, and it's not radically different if you're doing RV and LV. But the risk-benefit ratio, again, is going to depend on what kind of heart you're biopsying. Is this a very dilated, very sick heart, and the operator and the pathologist. So. But the clinical scenarios, I just want to stress this point where you really should consider it, or really should actually do it, is if someone comes in and they've had New-Onset and it's been less than 2 weeks, and they have hemodynamic compromise, you should be at least thinking about giant cell or eosinophilic myocarditis, because if you were to start immunosuppressive treatment, you may alter the course for this patient. So for the most part, we learned that with myocarditis, for example, like viral myocarditis, giving steroids, giving immunosuppressive therapy doesn't really change mortality, may alter the ejection fraction a little bit. But for patients who have like giant cell and things like that, it actually may delay time to transplant if that's the route they go down. So again, the purpose of biopsy is largely to rule out the things that we think would benefit from immediate treatment with steroids. And this is also just another slide showing that that if it's unexplained, and the first slide says 2 weeks, but if it's 2 to 3 months, 2 weeks up to 3 months, and again, there's some other high-risk feature and they're not responding, then again, you might do it to identify giant cell. And a class 2A recommendation is if it's greater than 3 months and you think they could have sarcoid or idiopathic granulomatous myocarditis. Less commonly, I don't envision too many scenarios where you would do this, but anthracycline, if someone has an allergic reaction to something, and eosinophilia, you might consider it maybe to get I don't know. But I just want to differentiate between that and hypersensitivity myocarditis, which is not the same thing. So you have some type of systemic allergic reaction, you have eosinophilia in your blood, and you get a hypersensitivity myocarditis, which is different than hypereosinophilic cardiomyopathy, which is a sicker, bigger problem. If you have an unexplained restrictive cardiomyopathy, or if you suspect a cardiac tumor that is not myxoma based on imaging. We're coming to the end. So treatments, so it's going to depend on the cause. Obviously, you're going to try to identify and remove the offending agent, and treat with standard heart failure therapy, although can't say that there's any, for just the general dilated cardiomyopathy, walking in without, like this guy, without knowing precisely what it is, standard heart failure therapy may not change the mortality if we don't know precisely what the cause is, but it will certainly help with symptoms. And based on our literature of other non-ischemic cardiomyopathies, it should. So you want to also be able to provide hemodynamic or mechanical support. So in the patient who is excessively ill, they should be sent to a transplant center where they have advanced heart failure experience in advanced heart failure therapy, treat arrhythmias, consider transplant. And again, as I mentioned earlier, you want to try to identify patients who may benefit from immunosuppressive therapy. And there's a list of those patients right there. And again, the reason I just bring that up is because if these young patients who are really, really ill, they do get evaluated for transplant, and you can delay the time to transplant. Lymphocytic myocarditis, which is what oftentimes we also consider to be viral, but based on biopsy, but is consistent with viral. This is our way of describing viral myocarditis, meaning if you were to biopsy someone with viral myocarditis, you typically see a proliferation of lymphocytes. And we think it's likely due to a virus. And again, this is going to be mostly in a clinical context, which suggests some symptoms, some URI type thing that led up to it, maybe not. So we don't give antiviral therapy. I don't need to expand on that. We know that already. Viral panels are not particularly helpful because there's a lot of noise. There's a lot of positives because we've been exposed to various viruses. And as I mentioned earlier, we don't typically give steroids for this because we don't see a benefit in mortality or functional status. And there's a bunch of randomized trials. There's one that I cited here. This was 719 patients, but when you look at the individual studies, the quality of the studies was not great. So of those patients, they only did viral detection in 38% of them, and only 58% were positive. So meaning they picked up a virus. Again, it doesn't tell you which virus caused what, but we can extrapolate based on studies like this that there are certain viruses that are more commonly going to cause a viral myocarditis, but there's no true cause and effect. No difference in mortality whether you gave them steroids or not. We'll skip this just for I just wanted you to see, so this is often quoted. This is the myocarditis treatment trial investigators, a bunch of things published from this group. But I just want to point out that this is a cohort of, I forget this was like 60, it wasn't a lot of patients, less than 100, I think. But the overall mortality for the entire group was 20% at 1 year and 56% at 4 years. So the point of this slide was just to show you, and then it's immunosuppressive versus control, just to show you that overall the mortality is high. And I think that bears, that's important for the purpose of counseling the patient. And this is 60 patients. And again, this is just the point that I made earlier, that when they come in very sick, so patients who present with arrhythmia or MI-like symptoms versus someone who presents with actual heart failure, the patients who present with heart failure tend to do much worse over time. And this is a survival curve. And then in the last couple slides, I just wanted to pick up, wanted to mention a couple things about this. I would encourage anybody, fellow attending, to read this, because I thought it was a really good comprehensive review of how to approach non-ischemic cardiomyopathy in terms of risk stratification and how to counsel patients and how to know what's available to you so you can give them, meaningful information about what's happening, because it's pretty unsettling to be told you have an ejection fraction of 20%, but you don't know why. So we're obviously not going to go over this whole thing, but just know that your toolbox is some of the more traditional things, like serology, echo, lab values, but we should really be considering almost 100% of the time cardiac MRI unless there's a clear indication. And we should try to follow the literature to see how that's going to evolve as a diagnostic and prognostic test. There's some blood tests that are helpful, and I'll show you in the next slide that there are a whole slew of genetic mutations identified. But the writers in this paper advocate for re-imaging to look for reverse remodeling so that you can maybe discuss prognosis. I'm not sure how I feel about that, but it's something to consider. And in patients who are doing very poorly, we kind of rely on our traditional methodologies, which is trying to determine their functional capacity and cardiac catheterization. The endomyocardial biopsy at the very end there that says if suspicious, this is something you really would consider much early on, okay? So these are the people, again, who are doing very poorly early on. Here's just a list of the different gene mutations that have been identified, and so maybe someday we'll be actually, we'll have access to genetic counselors in cardiology, and we'll be able to consider that as a source of diagnosis. But anybody who you suspect familial, you should try to seek out genetic counseling, which can be very challenging, at least for cardiology. So in summary, it's common, estimated prevalence 1 in 250. Mortality is high. Etiology is very variable, and about 30% of them are considered idiopathic. I highly recommend you consider MRI for New-Onset without any very obvious cause. And immunosuppression is a reasonable approach in very select cases. I would pay attention to the risk assessments because they're evolving, and they're the same with the genetics. So that's it. Any questions?